Yes, sir. Start.
So I'll be presenting a case of unusual subretinal fluid following open globe injury. So several causes of subretinal fluid are attributed to trauma. Few case reports describe central serous chorioretinopathy like picture following trauma, but that's very unusual. We present a rare case of open globe injury who presented with CSR like picture while on treatment with oral steroids. The dilemma of considering other differential diagnosis and multimodal imaging will be discussed. So this patient was a 45-year-old neurosurgeon who was my colleague, and he was injured with a racket while playing squash with the anesthetist who was working with him throughout the day. His vision at presentation was PL with inaccurate PR. When I opened the lids, there was a scleral tear which was roughly 10 millimeters long, superior to the limbus. There was iris prolapse and hyphema. So immediately, with the help of the same anesthetist, I planned him for globe repair. So the scleral tear repair was straightforward. He had a superior scleral tear, which was repaired with vical sutures with the AC wash. And then finally, I closed the conjunctiva with fibrin glue. And this was the appearance at the end of the surgery. The patient was doing fine. While on day 3, I had a dilemma. He had increasing hypopion. There was mild increase in pain, few vitreous echoes. So I had a doubt whether to inject or not, but benefit of doubt given to the patient, and he was given intravitreal injections, and he did good after that. So he was a surgeon himself, so he kept on asking me when he cosmetically he found that his globe is restored. So he said that initially, what if we have missed a glass piece inside my eye? So as a precautionary measure, I did a CT on him, and along with that, the radiologist advised to do the CT of the spectacles also, because sometimes the Hounsfield unit could be deceptive and we could not pick up a glass piece. However, I had already done a X-ray at the baseline. Unusual inflammation, I also suspected whether the lens capsule was integrity is disrupted. So the OCT in such situations can be very helpful. The actual dilemma started after 2 weeks when we started developing subretinal fluid. Here you can see in the OCT. So I started thinking of post-trauma CSR because he was already on oral steroids and he was a smoker. I had not done a depressed examination, so I thought it could be a peripheral break or commotio retinae. But theoretically, I also thought of a very, very rare type of sympathetic ophthalmia, which is presenting in this eye. However, the multimodal imaging, when I zoomed into the OCT, I found that the outer retinal layers are dipping into the choroid here. And there was a very small RP aperture, which was leading to this CSR. So CSR due to this was a case of CSR due to RP tear. The sympathetic ophthalmia was ruled out based on the FFA. There was no disc leak or there was no inflammation, and I decided to stop the oral steroids. So this was because of the small RP aperture like tear, which was picked up on multimodal imaging. There was choroidal hypoperfusion most likely, and which led to collection of this subretinal fluid. However, in this case, the force was just enough to tear the RPE. Larger forces could lead to rupture of Brooks membrane or choroid rupture. So this case highlights rare occurrence of CSR post-trauma with RPE tear. Multimodal imaging confirmed the diagnosis in this case, and the dilemma to stop steroids for prophylaxis of sympathetic ophthalmitis also could be taken, the decision could be taken based on this imaging. Now this patient, this neurosurgeon, he is very happy. He is finally, his vision was 612 and he has started operating his patients, and now he has become like our brand ambassador, wherein he always uses protective glasses and educates people about this. Thank you.
So your diagnosis is that it's a separate entity, not associated with trauma.
Yes, sir. But in this case, we could pick up that there was a anatomical damage to the RPE, so it was most likely the fluid exudate from that area, sir.
But the injury was quite anterior.
It was quite anterior. He had some vitreous hemorrhage also, so most likely because of the counter coup mechanism, the posterior pole was had also received the impact.
So the final vision was 612.
Final vision is 612.
Yes.
The final vision is 612 because this area is not in the center of the fovea. It is slightly away. There is slight foveal thinning, but his vision is 612.
The final OCT?
The final OCT, this fluid had subsided, but there was a slight foveal atrophy. The CMT was roughly around 182, sir. But center of the
182.
fovea was fine. That foveal dip was maintained.
Maintained. Any question?
But 612 vision is difficult to, no, it's best corrected.
It is best corrected vision.
No, you told 10 mm long scleral tear.
10 long scleral tear,
Okay.
but it was not involving the lens or the visual axis, ma'am.
Okay, that
And
scleral tear, adjacent areas, retina, periphery, everything was okay.
periphery, subsequently after a
No
month,
breaks or
no,
holes,
no,
nothing, no
nothing.
intervention done.
Nothing, ma'am. No intervention.
Vitreous hemorrhage resolved on itself, or you?
The vitreous hemorrhage resolved on its own.
How many days?
It took almost around 3 weeks.
By 3 weeks, it was clear, and the patient got 612.
The vision was 612. There was some inferior vitreous hemorrhage which took a little longer time, but the vision was 612, and he has started operating now.
Okay.
You spoke about anterior chamber reaction with hypopion. What happened to that later on?
Ma'am, actually, this dilemma was whether it is a lens particle glaucoma, or it is endophthalmitis, or it is the hyphema slowly, which is settling down. So it was actually the hyphema. So another clue we got from this case, that whenever you have a pigmented red-colored hypopion kind of thing, which you are thinking in post-op scenario, you should wait and watch for some time if there is no increasing signs of endophthalmitis in this case. So it was actually hyphema in this case.
What message will you give after you manage a case of trauma?
So in this case, one is whenever the
What
media,
you missed in it initially?
initially if I would have done a OCT in the initial setting, then maybe, but that time the media did not permit me because he presented with PL
That is
vision.
not possible at that
Yes,
time.
at that time it was
But
not
I think
possible.
imaging should be done before going for repair.
But X-ray we had done, ma'am. CT we have not done. We, as per our protocol, we always do a X-ray because of medical legal requirements. But in every case,
X-ray
we do
will
not.
highlight only the
Metallic,
metallic
yes.
foreign bodies,
And
not
that
the
was
glass
yes,
particle.
ma'am. That was a night time, and the CT was taking slightly longer time. So immediately,
Okay.
in the kind of setup I work, so the CT was deferred.
Okay. Ideally, we should do imaging,
Yes.
then go for repair.
Yes.
We'll go to the next presenter. Please come onto the stage. Be ready, the next presenter. The next presenter 460, paper number. Intraorbital wooden foreign body mimicking a lid mass. Okay. Next presenter 966, AIOCT guided management of traumatic iris cyst. You are Dr. Uma? Okay.
Any other class present? Any other presenter? No more. Just 3 we have.
So, good morning everyone. I am Dr. Uma. I shall be presenting AIOCT guided management of traumatic iris cyst. So, iris cysts can be classified as primary or secondary. Primary cysts are of neuroepithelial origin, and secondary cysts are due to implantation, metastasis, long-term use of meiotics or parasites. So, traumatic iris cysts are classified as secondary iris cysts, which can be post-surgery or post-trauma, which can be
Timer on, please. Timer.
So, what is the pathogenesis of traumatic iris cyst? It is caused by intrusion of epithelial cells into the anterior chamber. So, the epithelial cells carry a high proliferative potential. So, sheets of epithelial cells proliferate into the anterior chamber and lead to cyst formation. Iris, which is a highly vascularized structure, is an ideal scaffold for proliferation of epithelial tissue. So we had a 13-year-old male patient who came with the complaints of blurred vision from distance and near since 2 months. He gave a history of blunt trauma to the left eye with a cricket ball 2 months ago. The best corrected visual acuity in the right eye was 20/20 for distance and N6 for near. However, the left eye showed distant acuity of 23/20 and near N36. The slit lamp examination of the right eye was well within normal limits. The left eye had an iris cyst containing serous fluid in superotemporal quadrant extending to the pupillary area. Fundus examination in the right eye was normal. Left eye we could not visualize the fundus, but a B scan was done and it was normal. This is the slit lamp photo of the left eye. It is showing iris cyst extending from the superotemporal quadrant, reaching right up to the pupillary area. Anterior segment OCT done through the cyst shows an elevated lesion. Patient was managed surgically. Anterior margin of the iris cyst was well depicted on the anterior segment OCT. So we did a side port entry at 8 o'clock and with the help of an MVR blade. And we drained the fluid with the help of 30 gauge needle, which was attached to a 1 cc syringe entered through the side port from the most prominent part of the cyst. Post-operatively, patient was started on topical antibiotics, which were continued for 1 week, and also topical steroids, prednisolone acetate 1% eye drops, which were tapered over 6 weeks. This is the outcome. The best corrected visual acuity of the patient at 6 weeks was 20/20 for distance and N6 for near, and the intraocular pressure was well within normal limits. So iris cyst, the treatment options available are, we can either observe if it is not causing any complications like glaucoma, decrease in the visual acuity, or we can go ahead with fine needle aspiration, intracystic injection of absolute alcohol, intracystic antimitotic agent injection, laser, or surgical removal. Recurrence complicates the management of traumatic iris cyst, hence surgical excision is usually the last resort. Long-term follow-up is required to monitor the recurrence, and if secondary glaucoma is present or a complicated cataract is present, early intervention is necessary. Thank you.
What was the age of the patient?
13-year-old.
13-year-old. How long this was there?
2 months.
Okay.
You made a side port entry?
At 8 o'clock.
Acha, why not directly into the cyst using a 30 gauge needle?
Sorry, sir?
Why not directly through the cornea into the cyst?
Because we were worried that it might harm the endothelium in some way. So
In any case, you have an OCT. AIOC2023 was there.
Yeah.
And the side port entry would cause some of the aqueous to leak out. It was quite close to the endothelium. In this case, the chamber might collapse.
Yeah.
It was very close to the endothelium, the highest point.
Yes. But we did, the needle insertion was not done close to the endothelium. We made out the most prominent point on based on AIOC2023, and then we aspirated the fluid.
Post-operative AIOC2023 you have?
Sorry, right now I don't have.
And the wall of the cyst, what did you do?
Sorry?
Wall of the cyst. You just aspirated.
We just aspirated the fluid.
Wall of the cyst was
No,
not.
we did not do any further
Should it be
surgical
done or
manipulation.
not?
If there is no complication, we should avoid, because there is a high risk of recurrence.
Yeah, if you don't take the wall of the cyst, it will recur.
How long did you keep the patient in follow-up?
For 6 months, 6 weeks, and then for 6 months. At 6 months, there was no recurrence.
But during the duration of 6 months, you didn't repeat the OCT, AIOC2023?
Yeah, we did. Right now, I don't have
You
the
don't have
picture.
it.
Yeah.
We'll move on to the next speaker.
Next president.
Yeah, whoever is there, please come, because many are not there here. May I know your free paper number? Tackling the pediatric orbital floor fracture.
Good morning, everyone. I'm presenting on tackling pediatric orbital floor fracture when less is more. Pediatric orbital floor fractures have unique mechanistic and healing patterns, but still are managed with adult fracture guidelines. Our aim was to compare final outcome between non-surgical and surgical management of orbital floor fractures in pediatric age group, and to propose a possible management protocol in pediatric floor fracture based on clinical features. A total of 38 patients aged less than 18 years with pure orbital floor fractures were included. Their signs, symptoms, ocular evaluation, diplopia charting, in-ophthalmos measurement, Hess charting was done. CT scan was done to look for fracture type, site, muscle, and or soft tissue entrapment. And we divided pediatric blower fractures are divided based on CT findings as group A, trapdoor fracture, group B, floor fracture with incarceration, group C as depressed floor fracture. And group A, trapdoor fractures which needed immediate surgery via transconjunctival approach. And group B and C are non-trapdoor fracture. If there is gross motility restriction of -3 or -4 and it needed immediate surgery. If there is mild or nil in restriction with or without diplopia or inophthalmos, it needed conservative management. Criteria for success we considered as nil diplopia in primary gaze, inophthalmos of less than 2 millimeters, no hypoglobus, EOM restriction of less than 5 degree in upgaze but normal in other gazes. Coming to results, a total of 38 patients, 31 were males and 7 were females. Mean age was 12.4 years, and 50% was 50% were due to sports injury, and least was due to motor vehicle accident. Group A, trapdoor fractures. Total of 7 patients had trapdoor fracture. Among that, 5 patients had white-eyed blood fracture, and because 1 patient had residual 10-degree upgaze restriction, so 6 out of 7 were successful. And group B, floor fracture with the incarcerated tissue. Total of 19 patients, 16 were conservatively managed, but because of the non-resolving primary gaze diplopia, 2 had to be surgically managed, and other 3 patients were surgically managed. 5 out of 5 were successful. And group C, depressed floor fracture. Total of 12 patients, 10 were conservatively managed and 2 were surgically managed along with those 3 of conservative group, as 1 had non-resolving primary gaze diplopia and 2 had significant hypoglobus. 4 out of 5 were successful. 1 had residual 10 prism diopter upgaze restriction. And coming to discussion, pediatric trapdoor fractures, including white-eyed blood fracture, warrant immediate surgical repair to prevent sequelae of oculocardiac reflex and muscle fibrosis. And optimal management of non-trapdoor fracture remain controversial, but non-trapdoor fracture with mild or nil movement restriction, we can wait and watch. And at 2 weeks of follow-up, if there is no diplopia, we can wait and watch. And at 4 to 6 weeks, if there is persistent primary gaze diplopia, surgery is needed. And in case of if there is inophthalmos at 4 to 6 weeks of follow-up, if it is noticeable, and the surgery depends on decision of parents. We concluded that considering the risk of orbital surgery, risk of anesthesia, non-trapdoor pediatric fracture, surgery can be delayed till edema and inflammation resolves. Surgery only if clinically significant diplopia or noticeable inophthalmos is there, and surgery if decided to be done, then a simple transconjunctival incision over a cutaneous incision was sufficient. Thank you.
How many days or years these many patients you could gather? 38 patients.
Over 6 years.
Over 6 years.
Yes.
What your study is adding to the existing literature?
So we thought we can manage conservatively for those who didn't have gross extraocular motility restriction. So we can wait and watch. Even if some patients were not bothered about inophthalmos, we can wait and watch.
Why does inophthalmos happen?
Sorry?
Why does inophthalmos happen?
Immediately after injury also we could see inophthalmos.
Madam is asking, what is the cause of inophthalmos in these blood fractures?
Because of the extra fat tissue prolapse, or
Where?
because of the countercoup injury, hydraulic pressure, the orbital trap would have trapped into the extraorbital tissues.
Wherein it prolapses? Why not any other? Why not medially?
Medially,
Yes.
because of the bone.
Inferior is also there's a bone. Okay. What are the problems with intervening surgically?
In pediatric age group, these are pediatric patients, sir. considering the risk of anesthesia and growing bone in the children. So in some cases we can wait and watch.
Anything else? Any other surgical problem? Okay.
What are the indications of surgery and how long do you wait for it?
For some patients, we waited for 12 weeks, ma'am, 12 to 24 weeks. If
What type of
there
patients?
is, in case of non-trapdoor fractures, ma'am, if there is no muscle entrapment and if there is no gross motility restriction, we just maintain them on anti-inflammatory and all.
No, when there is entrapment, how long do you wait?
If there is significant entrapment, immediate surgery.
What do you
was
mean by
needed.
significant entrapment?
Forced duction, gross motility restriction of -3 or -4, and the forced duction test was positive.
So what is the indication of immediate repair?
In case of white-eyed blood fracture, there is no significant ecchymosis or no external signs, but still patient will be having bradycardia or other signs, and
What are the other signs?
bradycardia, syncope, and other vitals.
For immediate repair, you have to see the go for the symptoms like nausea, vomiting, bradycardia. So you have to plan the surgery immediately. Otherwise, you can wait for it. And what is the difference in the fractures between the children below 7 years and above? More smaller children? What type of fracture is common?
In smaller children, medial orbital fractures are more common. In adults and all, floor fractures are common.
I think it's not that way.
Yeah.
Okay.
Thank you.